every year and pay for it if you actually want to do it. It's not an expensive survey. It's not DHS, how much is it, Carla? 800 million. So in a sense, if you move away from being still thinking the phantom limb service provider, then you will get stuck spending all your money in doing things that is no longer what you're supposed to be doing. You start being an enabler, things will naturally happen. Great things will naturally happen.
Yeah, that's a segue to what I'm going to talk about the joint planning. Because it's thinking differently and working together. But I think Secretary wants to make a few comments.
Maybe just to clarify things. The DOH ZFF partnership was for 3 years. DOH actually, I estimate, putting around 400 to 500 million, covering costs. ZFF was not paid by DOH. We covered our costs. As a matter of fact, some of the training programs we picked up. And in the period of 3 years, we put in around 100 million for this. And I think what made the partnership work was that it was truly a partnership. We are not a contractor, or we are not a provider. And I think with that, it made things easier to work with DOH, and it made things easier to work with the non-DOH. If we accepted DOH money, then we will become suspect. Then if people will start saying, bakit yung willing farma na dyan? So instead of just willing family foundation, the other, the other things come to the picture. So I think that's what the partnership is.
Okay, Dr. Roa will speak, and I would like to ask Dr. Arlina, because one of the major issues is LGUs. First, Dr. Camilo Roa. Yes.
I would talk on the perspective of being part of the private medical practitioners. As shown in the slides of Dr. Leason, only less than 5% are actually in the government. So if you can harness the rest of the 95 or more, that would be a big resource. Actually, I'm speaking, having been into some NGO work and TV advocacy, that the private sector is ready. It just has to be helped to adapt to its role. And I would like to also say that there is some hesitation in partnering on both sides. But if the two sides will have some hesitation, who will move first? It should be the government. The government has the mandate, the government has the money, and then it will create a force of collaboration. We've seen this in tuberculosis. Every year we have a meeting, we work together, participated by private as well as government members. Together, write the same slogan, and we also created some data. We had a study on TB among prisoners, and because of that, we got data that allowed us to come up with a program addressing the issue, because it is in prison where we breed alcohol resistance that goes to the community. So we are ready, and I think I speak for the group of private medical professionals.
Yeah. Before Dr. Lachon wants to say a few words.
I think the basic reason why we are all here is that there is a sense of urgency. In the book of John Carter, you need to declare a crisis right now. The country is in crisis, particularly health. I mean, all of you know, based on the data, that we have a crisis in workforce, financing. You may have money, but it's not put in the right place. You have a lot of problem in infrastructure. So the first one is to declare there is a healthcare crisis. And then all of you here are present because of that particular sense of urgency. Therefore, the next step is a guiding coalition. And then you need to communicate the vision. Because a goal without a timeline is a dream. You need a blueprint here, and you need to communicate the vision so that you can actually create that imagination for the people. I think the basic reason why you're all here is that we need a very nice health agenda. But if you don't declare, There is a healthcare crisis now. You cannot hit the headline tomorrow. You will not. You will not. And we'll be talking again the same problem next year for the next 6 years.
You have an ideal LGU health setup, and we would like to learn from you. What have you done right? How is the priority, and how does it work for you?
Actually, I was about to raise my hand so I can talk before this discussion finished or not. And I would like to share the health inequity, the first one, okay, in relation to the LGU's response to PhilHealth, okay. So, the utilization or the coverage of PhilHealth actually is high, isn't it? But in reality, the utilization is very low. And our data will show that and can prove it, especially with the NHTS. It's in all our lying clinics, it's about only 2% of the NHTS can avail of the field, and the rest are coming from the private citizens. Okay. So what does it mean? So what is the role really of the LGU in terms of field health? We have a big role. Actually, we have 90% our role. One, we look for this field health enrolled by in NHTS. It's just all the papers are going down to us, bulk of registered or paid by the government, by the national government, and in all parts of Quezon City, we're looking for these patients. We're receiving a lot of the member data form, okay, and it's just to find out that we cannot locate them because it just says Barangay Payatas. And Barangay Payatas, Barangay Commonwealth, Barangay Silangan, Barangay Holy Spirit, those are very big barangays. So, and we clamored that during our conversation or stakeholders meeting with PhilHealth. But until now, it was not addressed yet. Okay. I think the problem is information technology again. So let's go back to how do we deal with this information technology. The data gathering is one, okay? Now, we profile, we enlist the patient, but what is good in Quezon City, we are also enrolling our constituents under PhilHealth by the city government, under Mayor Bautista, with Swelling Foundation, no? In coordination with UNICEF, the latest city leadership governance program that we had, in which we are one of the, shall we say, graduates, the newly graduates. Quezon City is one. There is a strategy that we did. No? One is we enrolled together with our SSTD, the equivalent of the national government TSWD. We guide the patient, especially our adolescent, in enrolling with the guidance of the parents or the significant others because they are minor. We bring these documents to PhilHealth. SSTD paid it to 2,400 one time. So we did all the lot of that and we found it's very successful, unlike those being enrolled by NHTS. So that's one of the strategies that we did. Another one that we encountered, well, I am very sorry to see tatamaan. I'd rather deal with the private sector rather than my own national government. And that's the reality, no? It's really very hard to talk to them in terms of partnership, no? Parang ang hirap isbelengin. I really don't know if they know the program, no? Because there is one medical director who told me, ginagawa na namin yan, PhilHealth enrollment. But we want to communicate it directly with them through an information technology. Bakit pa kailangan, no? Why do we need that, no? So it's very frustrating on our part that we from the government going to another government hospital, we find it very difficult for us. As a matter of fact, these private sectors and development partners, they have a more convincing framework, mission, vision, and highly varied objectives that can really address our concern. Maganda ang kanilang plataforma.